This is St. Louis on the Air from St. Louis Public Radio. I'm Elaine Cha. Technology for prescription drug monitoring programs was originally designed for law enforcement, and since the early 2000s, healthcare systems have used those tools to combat misuse of prescription meds. Yet these approaches haven't fixed the opioid crisis. In fact, the epidemic continues to worsen. Why? St. Louis University Associate Professor Liz Chiarello recently published a paper in the American Sociological Review that examines that question, and she joins us today to talk about it. Liz, welcome back to the program.
Thank you so much for having me.
Let's get a little bit of background here. So prescription drug monitoring programs, or PDMPs, are nothing new. Pharmacies have used these since the 1940s, but it became prevalent in the 2000s. Why is that the case, and what is it that accounts for their presence and use so broadly now?
You're correct. They've actually been around since 1918. The first one was developed in New York in 1918. So we've had some way for law enforcement to track prescriptions for over 100 years. But of course, that was before everything became digitized. They became really popular in the early 2000s once the overdose crisis really started to rev up. And they were motivated by these grants called Harold Rogers grants that came through the Department of Justice. They helped states set up the prescription drug monitoring programs and then helped them run those programs for some period of time. And they, of course, became more popular because everyone was looking for some answer to dealing with the mounting overdose crisis.
So the objective then was about minimization of harm?
That was ideally the goal.
Mm-hmm.
Yeah.
So insofar as the way that they work, how do these programs operate, like in practice?
So in practice, you go to the pharmacy and you get a prescription filled for hydrocodone, let's say. The pharmacy transmits that prescription as well as any other controlled substance prescription. I want to be clear, we're not just talking about opioids. We're talking about a wide range of medications. They transmit that information to whatever state agency runs the prescription drug monitoring program. So in Missouri, it's in the Board of Health. In California, it's in the Department of Justice. In Florida, it's in the Board of Medicine. So it kind of, in the Board of Health. So it kind of varies depending. But there's a company that they work with through a public-private partnership. It's called Bamboo Health. It used to be called Apris Health. Mm-hmm. And that organization compiles the information and then feeds it back to healthcare providers and to law enforcement who use it for surveillance purposes.
Mm-hmm. So what is it then that brought this issue of that intersection of what's happening with healthcare systems and law enforcement? What brought this issue to your attention?
Well, I had been doing work for my dissertation really on emergency contraception. I was in the reproductive health space for many years. But when I did my research on pharmacists and decision-making, I was interested in the kinds of ethical issues that they make in daily practice. And I wanted to talk about reproductive health, and they wanted to talk about opioids. And so I got all this data about how they were making decisions about providing opioids. And they were really at a loss. This was in 2009. They were seeing a lot more people who were misusing medication, but they didn't have a lot of guidance in terms of how to deal with those patients. And you have to understand that pharmacists are very exacting people. Mm-hmm. They want to do exactly the right thing.
Okay.
And this was a really complicated problem. And so I followed that after I had done that research and started to see these kind of medical partnerships between medicine and law enforcement trying to work together to deal with the opioid crisis. And that's when I first learned about the PDMP, the Prescription Drug Monitoring Program. And I thought to myself, well, what is this? It seems like it's an enforcement technology that's being used in healthcare spaces. So how is that going to work? Is it going to operate like an enforcement technology, or is it going to operate like a healthcare technology?
Yeah.
And that's what really led me into the project that we're talking about today.
Mm-hmm. So then with these two fields, there's healthcare and criminal justice. They're working together. So would you say that the intent is one that was positive? And if that's not the right way to put it. How would you characterize it?
The intent of developing the prescription drug monitoring
Oh,
programs.
and then the working together.
The opioid crisis, I think, just came. It's not that it came out of nowhere, but it certainly escalated really quickly. And I think that there was, at first, nobody wanted to touch it. The people that I was talking to who are law enforcement leaders, for example, they said, we don't want this. This is something that medicine has created, and now they've stuck this problem in our lap. Because I started this project thinking it was going to be a story of competing institutions, so that you were going to have healthcare trying to stake its claim and law enforcement trying to stake its claim. But in fact, at first they were like, not our problem, and then over time they took this more all hands on deck approach, where they said, well, we can't handle this problem on our own, and that I think is what motivated the prescription drug monitoring programs and a lot of other activities that blur the boundaries between treatment and enforcement.
Mm-hmm. And what was your sense in talking with pharmacists and why it was that they were using these prescription drug monitoring programs? Like, what benefit were they seeing for the work that they were doing or for the patients they were dealing with?
So one thing that's important to understand is that pharmacists operate from a place of uncertainty, especially when we're talking about opioids. Pharmacists usually don't have access to the medical records, especially if they're working in a community pharmacy like a Walgreens or a CVS. Mm-hmm. And they have to make decisions very, very quickly. A busy pharmacy might be filling 400 prescriptions a day, and so they just have to dispense. And so that doesn't give them a lot of time to reflect on whether this is the right medication for the right patient. They're juggling a lot in a very short period of time. Now, they also have their pharmacy has a DEA registration, and the DEA wants them to be very cautious about the medications that they're prescribing. So they have to be cautious and quick, and they have no idea. And early on, they were really struggling to do both of those things at once. Mm-hmm. The PDMP solved that problem for them because they could look somebody up in the monitoring program, see the medications they'd been getting, where they'd been getting them, how often, and they could use that to make a decision. And that was much faster than asking the patient a lot of questions, relying on their gut instinct. Mm. And so I think it was more, it had some benefits in terms of workflow.
Okay. Now, as far as the pharmacist-physician relationship goes, that's something that maybe people don't think about. It's just the prescription that you get, and then you take it to the pharmacy, and then that prescription gets filled. I mean, to what extent is it a pharmacist's job to determine the right medication for someone? Do they have a role in that?
They absolutely have a role in that. So the Controlled Substances Act, which was enacted in 1970, gives physicians a requirement to make sure that they're working with a legitimate patient for a legitimate medical purpose. And then it gives pharmacists what's called a corresponding responsibility to make sure that that medication is legitimate. But again, pharmacists historically have not had access to the medical record, and so they're picking up on social cues and red flags and trying to make this decision. The PDMP gives them a lot more information. Mm. But I think a lot of people don't realize that pharmacists are decision makers and gatekeepers, and some people push back on the idea that they should be. But anyone who's ever had their lives saved by a pharmacist questioning a prescription is really grateful to pharmacists. They act as a really critical check and balance on the physician. If we lived in a world where pharmacists just dispensed everything that physicians wrote, we'd have a lot more medical error than we have now. Mm-hmm. So they most certainly have a role, both legally and ethically.
Right. We're talking today about the efficacy of prescription drug monitoring programs with Liz Chiarello, Associate Professor of Sociology and Anthropology at St. Louis University. Liz has recently published a paper in the American Sociological Review. That looks at the relationship between pharmacists and healthcare system and these prescription drug monitoring programs. Liz, what do we know about the effect of PDMPs on the number of people who are in addiction or the number of overdoses that have happened?
Well, so the research is mixed. There is one thing that prescription drug monitoring programs are really good at, and that is bringing down prescribing rates. And so the theory goes that early on in the crisis, when a lot of overdose was associated with prescription medications, that if you could just cut back on the prescribing, you would then cut back on overdose. Well, we're at a point now where prescribing has returned to pre-crisis levels, but overdose is through the roof. And so clearly, if we were going to solve the problem by clamping down on prescribing, we would have done that already. But instead, what's happening is patients are being shut out of the healthcare system and left with nowhere to go, except for the rather toxic illegal drug supply that is increasingly has more dangerous drugs. For a while it was heroin, now it's fentanyl. And so it's not like addiction goes away the minute the patient walks out the pharmacy door.
And as far as the kinds of drugs that people are that they're getting prescriptions for, you said that there has been a little bit of a dip. I think there was a lot of attention to certain kinds of prescription drugs that were being abused or misused, that is, by people who are dealing with, chronic pain. I mean, how is it that prescription drug monitoring programs affect those who have those kinds of conditions and need those medications to live, just get by day to day?
So usually when we're talking about prescription drug misuse, we're not talking about chronic pain patients. We're usually talking about people who have substance use disorders. So there are two groups of people. There are the people who have substance use disorders, which is what we think about as addiction. And then there's a group of people who have chronic pain. And both of those groups, in the heyday of opioids, were likely getting opioids from physicians and from pharmacists. And in our current rather conservative period where we've really clamped down on opioid prescribing, neither of those groups are getting access to opioids. And there's been a real push to taper chronic pain patients down if they've been on really high doses of opioids, to taper them down without a corresponding evidence of effectiveness at doing so. And so a lot of chronic pain patients are talking about being kicked off of their opioids, being catapulted back into pain. Some people are ending their life by suicide. And so it's really a tragic picture of what's happening to folks. And then people with substance use disorders, instead of getting a regulated medication where you know exactly what's in it, you're taking whatever you can find on the street, which more often has something in it that is stronger than what you would have gotten in a pill.
What are some of the flags for the way people are coming in that could indicate to someone having to make a decision about whether to dispense the medication? What are some of those flags that get raised? And in particular, how does that affect certain groups of people more than others?
So flags now with the flags before the prescription drug monitoring program looked a little bit different. They were things like somebody's appearance, somebody's behavior, the way they talked to the pharmacist, if they had come from a long distance, things like that. With the prescription drug monitoring program, some of the prescription drug monitoring programs calculate what's known as a risk score. And that's supposed to indicate likelihood of overdose. So that's one red flag or measure if the risk score is high. Other things involve seeing multiple doctors, going to multiple pharmacies. Increasingly, pain patients are required to sign a pain contract, which is a legalistic document that essentially says, you're only going to see me. I'm your only physician. You're only going to this one pharmacy. I'm going to test your urine on a regular basis. I'm going to check you in this prescription monitoring program. And some doctors at the extreme say, I can call you and tell you that within 48 hours, you have to show up at my office and I'm going to count the number of pills that are in your bottle to make sure you're really taking this drug that I've prescribed. And so going to a lot of different pharmacies or a lot of different doctors indicates that a patient might have violated that pain contract and is quote unquote drug seeking or is, doctor shopping or pharmacy shopping is the language that folks use.
And how binding is that contract?
Well, it's not binding in that they'll take you to court, but it is binding in that there are fewer and fewer doctors who are willing to provide opioids to pain patients. And so if I cut you off, if I tell you you're no longer my patient, you're unlikely to find another doctor who's willing to take you on, not only because of these behaviors that show up in the PDMP, but also because you just got fired from your last doctor and they're going to want to know why that is. And so in terms of the consequences for you and your healthcare treatment, they can be rather profound.
Now, one of the things that you've said is that PDMPs are a Trojan horse technology. Talk to us about that.
So we usually think about the Trojan horse metaphor as a way of describing smuggling something harmful in the guise of a gift. And prescription drug monitoring programs were essentially a gift. They were a gift from law enforcement to healthcare. And they're a way of giving law enforcement access to data that they normally don't have access to, which is information in the electronic health record, which is protected by HIPAA. But prescription drug monitoring programs are not protected in the same way. They don't enjoy the same privacy protections, which is part of how law enforcement is able to get access. But it's a Trojan horse technology because, actually, I should point out. So the Trojans were horse people. That's part of why the horse symbol was so powerful for them and why they were so excited to receive this gift of the horse. Similarly, healthcare is used to electronic databases. The electronic health record is a really good example, and the prescription drug monitoring program looks a lot like that, which helps explain why healthcare was so eager to adopt it. But hidden inside of it are surveillance, policing, and enforcement logics that creep out over time as healthcare providers use the database. Now, I don't want to give the technology too much power. It's not like the tech is doing all of this, but the tech, along with changes in law, changes in organizational culture, are all helping to shift pharmacy towards policing in a way that it hadn't been before.
And what are the in real life effects of that creep, the function creep?
The real life effects are, patients are being questioned at the pharmacy counter. Patients are being turned away. I think, people say to me, and certainly pharmacists would say, well, I'm using this as a healthcare technology. It's not a surveillance technology or an enforcement technology. I'm using it to do healthcare. But the problem is pharmacists' best option is to turn that patient away. That's not healthcare. That's refusal. And we have to think about where that patient ends up. If pharmacists were using the prescription drug monitoring program and then offering patients more resources, they were saying, look, I can't give you this, but I can initiate you on buprenorphine today, or I can give you methadone today. That would be a really different situation, but that's not where we are. We're at a place where pharmacists use a surveillance technology to refuse to provide care to the patient, or in some extreme cases, to call law enforcement and encourage them to target the patient. Again, that's not healthcare as we normally think about it.
Yeah. I mean, and targeting, by that, we mean that they could face arrest.
Absolutely. And they can face arrest for two reasons. I mean, the pharmacist can basically do a warm handoff to law enforcement. They can call law enforcement and encourage them to investigate the patient. Or they can abandon the patient, and then we can reasonably expect that those patients will turn to the illegal drug supply, where, again, they're at risk of arrest. So, again, we're blurring those boundaries between healthcare and law enforcement.
Yeah. I mean, big picture, what concerns are there with uses of this technology? And is there any way to get out of that system?
To get out of it as an individual?
As an individual whose information is being tracked by these prescription drug monitoring programs? I mean, is it basically once you're in, you're in?
Yes, once you're in, you're in. It's not, I think there are ways to correct it, but I believe it's a very long process. It's not like a credit score where you get access to it, and you can easily look it up, and then you can challenge some of the charges that are listed. Instead, Many people don't even know that the prescription drug monitoring program exists. But if you're taking benzodiazepines to treat anxiety, if you're taking opioids, there are a number of other medications that are being tracked, and you might not realize that your data is going into the system. But no, you can't easily see your report, and you can't easily opt out of the system. It's pretty automatic. And then I think the bigger picture in terms of thinking about function creep and thinking about Trojan horse technologies is, what is the purported use for a technology, but what are the intended or unintended consequences of using a technology designed for one field in another field? In this case, it's designed for law enforcement. It's used in healthcare. But what are the other technologies that help to blur boundaries between fields in ways that might undermine the very core of the field that's using them?
This episode was produced by Emily Woodbury.
Audio engineering and podcast design by Aaron Dorr.
Our executive producer is Alex Hoyer.
St. Louis on the Air is a production of St. Louis Public Radio. Understanding starts here.
St. Louis on the Air proudly supports local artists by using music from Life Creative Group.
Do you find yourself regularly listening to episodes of St. Louis on the Air? Suggest us to a friend you think might enjoy our conversations. And leave us a review and rating on Apple Podcasts on the App Store. It's the simplest way to help people discover our show. Thanks.
St. Louis Public Radio is a member-supported service of the University of Missouri St. Louis.
Support comes from the Missouri Forest Products Association. Missouri produces wood pallets, railroad ties, white oak barrels, hardwood floors, and more. Details on the variety of products made in the state are at choosewood.com.